What's up, Ninja Nerds? In this video today, we're going to be talking about sodium disorders. That includes both hypo and hypernatremia. Again, this is a part of our clinical medicine section. If you guys like these videos, they make sense, they help you, please support us. You can do that by hitting the like button, commenting down in the comment section, or subscribing. Also, for your true benefit, I really believe that we have some awesome supplemental resources, things like notes, illustrations, quiz questions. You can find all of that on our website. How do you get there? Go down in the description box below. There's a link that goes right to our website. All right, let's start talking about sodium disorders, my friends. Let's talk about the first sodium disorder, which is hyponatremia. So when the sodium level is too low. How low? Well, usually we say less than 135 milliequivalents per liter is the roundabout number by which we say, okay, below that, it is now considered to be too low. It's called hyponatremia. Well, then we have to think about the pathophysiology behind hyponatremia. Oftentimes, the most common etiological factor is that there's just more water relative to sodium. So then you have to think about what hormone really regulates water, and that's ADH, or vasopressin. So ADH really helps it to work at the collecting duct to reabsorb water across it into the bloodstream. And if we have more water in the extracellular space than there is sodium, we dilute down the sodium. So then we have to think, what are the things that are increasing ADH levels? Well, if they're appropriately increased, then we have to have some particular triggers or stimuli, right? And what are those triggers? So the triggers, or the stimuli, there's a couple of them. But I'd say the most important ones are going to be when the blood volume or the blood pressure is low. All right? So usually it's when the blood volume is low. That's oftentimes a very potent trigger. There can be other ones. Oftentimes it's kind of related here where it's usually due to your blood pressure's low, but both of these, and oftentimes both of these work kind of in tandem with one another. And what happens is that these circuits help to be able to, when your blood volume's low, your blood pressure low, it activates your juxtaglomerular cells and they produce a hormone, which is called renin, which leads to the formation of angiotensin II, and we'll go over that. But these are the primary triggers for an appropriate increase in ADH. Let's understand that for a second. So let's say here I look at my circulation. Right, in both of these scenarios here, blood is circulating through my vascular system. But what I know is that my blood volume is low or my blood pressure is low. When that happens, what that does is it tells our cells in the kidney, because what happens is our kidneys are very sensitive to perfusion. So when the JG cells sense that the blood volume is low or the blood pressure is low, they pick up on that. And these JG cells become activated. And they make a hormone, or an enzyme, if you will, called renin. And what renin does is it leads to the formation, eventually, of angiotensin II. And if you guys know anything about angiotensin II, this is a very potent hormone. It can do a ton of stuff. Literally, it's a jack of all trades. What this guy can do is it can vasoconstrict blood vessels to pump up your blood pressure. It can help to increase aldosterone to bring more sodium into the bloodstream. But here's another thing. It can activate our hypothalamus and stimulate the hypothalamus to send signals down via the posterior pituitary and secrete a hormone in very large amounts. So now I'm going to have a lot of this hormone in the bloodstream. What is this hormone? ADH. When ADH is released, what it does is it goes to the kidneys. Here's a nephron. If I take one nephron and I zoom in on it, here's my proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct. At the collecting duct, there's receptors for ADH. These are called V2 receptors. Another name for ADH is vasopressin. When ADH goes, it binds on and stimulates these receptors, which triggers an intracellular cascade. This intracellular cascade leads to the formation of these little subunits, these little pores that form within the luminal membrane. When they open up, water will flood into the bloodstream. So water will move from the lumen across the cells into the bloodstream. So what happens now? If I bring more water as a response into my bloodstream, I theoretically increase my blood volume and blood pressure, which fixes the issue. But the downstream consequence which can result here, which is what we're talking about, is I could dilute down my sodium. And via a dilutional effect, I may bring the sodium down to pathological levels. To what? As we said, less than 135. So this is the concept that I want you guys to understand here. Now, another thing that's really important here is when ADH levels are high, if I reabsorb via this pathway, tons of water, what happens to the amount of water that's present within the urine? Very little, because I'm reabsorbing a lot of that water. So as a result, here's a really high yield important thing to remember. There is very little water that is present in the urine. And what that does is that makes the urine appear more concentrated. But what that means is when the urine is concentrated, the osmolality of the urine is very high. So what I want you to remember is that the urine osmolality, as a result here, will be very high in high ADH states. So one thing important to remember is whether it's appropriately increased ADH or inappropriately increased ADH, what happens to the urine osmolality, my friends? You're going to have a high urine osmolality. Now we'll talk about what that true number is more in the diagnostic section. Just in case you want to know it, it is 300. That is kind of like that number. But you'll see these are the same. It indicates that ADH is turned on. Now, trigger for this is blood volume and blood pressure is low. And we'll talk about some of these causes. What about for this one? Has nothing to do with blood pressure or blood volume. That is the big thing. Has nothing to do with the blood volume or the blood pressure. So it has to be due to, so no effect from blood pressure and no effect from blood pressure and blood volume. The primary trigger for this is usually certain types of things that are very odd, peculiar. And what we'll talk about a little bit later is this often is due to a disease called SIADH, syndrome of inappropriate ADH secretion. There's so many different things that can trigger this that is very inappropriate, very random. We'll go over them a little bit later. Intracranial disease, pulmonary diseases, drugs, and even endocrinopathies. Okay. So we have an understanding here that the primary trigger for appropriately increased is low blood volume, low blood pressure. For inappropriate, it has nothing to do with the blood volume and blood pressure. It's SIADH. But the urine osmolality in both of these is high. Let's compare and contrast to the opposite. What if I have a scenario where the ADH is suppressed? It may be normal, but it's lower than what we would like it to be in these situations. That's interesting. So now, what would be particular triggers that I have to ask myself that would cause the ADH levels to become lower? So it's not high. Well, there's really two particular reasons. One is that your water intake is way higher than your ability of your kidneys to excrete that water. Or the second thing is that your solute intake, the amount of electrolytes, sodium, other types of electrolytes that you're taking in, is way, way lower than the amount of solvent that you're taking in, or water. So these are oftentimes the two particular things here, is that you have a very high water intake, we'll say. Water intake. Or a very low solute intake. Now, watch this. Let's say you have a very high water intake or a low solute intake. It's usually a combination of these. So in this scenario, if you have water, lots of water, or very low solute, what happens to your plasma osmolality? So now look, in my circulation here, I'm going to have lots of water. And I'll talk about how you get this water in there eventually. But if there's lots of water, what does that do? That kind of in a way says that my blood volume is appropriate, my blood pressure is appropriate, right? So there's two ways that I could look at this. I could say that my blood volume and my blood pressure should be appropriate. And if in that scenario that is the case, what should that do to the renin, angiotensin, aldosterone system? It should, in theory, help to suppress this production of renin, angiotensin, aldosterone system activity. So this should be decreased. In other words, that's not really driving ADH production. All right, so it's actually not going to lead to ADH production. Well, here's something else that's interesting. If your amount of water in your bloodstream is a little bit higher, you know what that does to your plasma osmolality? It brings your osmolality, the concentration of your bloodstream, lower because you have more water, less solute. So now my osmolality is low. Guess what osmolality, when it's low, guess what that does to ADH? Suppresses it. So in both of these scenarios, guess what it's doing to your hypothalamus? It's kind of suppressing your hypothalamus. So then your hypothalamus in this response produces less ADH. If it produces less ADH, what happens then? Do I have as much ADH present to bind onto the V2 receptors? No. If I don't have as much of this ADH to bind to the V2 receptors, then will it help to stimulate the formation of the aquaporin subunits? No. Will I express these on the membrane? No. Will I bring water across here into the bloodstream? No. And all of this is what leads to me bringing less water into the bloodstream. But what happens now? If I'm not reabsorbing as much water, where does this water go? Right into the urine. So now I'm going to have a buttload of water here in my bloodstream. In my urine, I apologize. A buttload of water in the urine. That means that the urine is dilute. If the urine is dilute, what happens to the osmolality? The urine osmolality will drop. And if it drops to less than 300, that tells me that ADH is turned off. Right away, I can differentiate between those types of ADH dependent and ADH independent hyponatremia. So now in this scenario, urine osmolality is low. Why is this so important to understand, guys? Because right away, when you get a patient who comes in, they have a sodium less than 135, guess what you're gonna do? You're gonna go and you're gonna send off a urine osmolality because it's gonna tell you right away, is it an ADH dependent or ADH independent process? Now you're probably thinking, okay, well, if I'm not reabsorbing as much water here, how am I diluting down the sodium, Zach? Remember, you're taking in lots of water or you're taking in less solute. And so because of that, in this effect right here is how you're going to drop the sodium to less than 135, right here via this effect. Okay? Now, let's take some time and go over thinking about what are the reasons why ADH is so high in low blood volume or low blood pressure. Why is it so high in SIADH? And then what happens to the causes of hyponatremia in patients who are appropriately suppressed with their ADH because they're taking in too much water or too little solute. All right, my friends, so now we've covered the pathophysiology. The next concept here is that we have to then say, okay, in order to determine the causes of hyponatremia, I can really kind of narrow down my diagnosis using the urine osmolality to see if ADH is high or ADH is suppressed in that scenario. But the next thing that we have to do is we have to look at the volume status of the patient. And we'll talk a little bit more about this in the diagnostic section, but you're kind of evaluating mucous membrane, skin turgor, you're looking at their blood pressure, their heart rate, you're looking at their jugular veins, you're looking for any visibility of edema in their legs, ascites, you're auscultating the lungs to look for rales upon auscultation. So a lot of evaluation is going into that. And then what you can do is you can group these patients into three particular categories. Are they hypovolemic, euvolemic, and then the last one we'll talk about, hypervolemic. The hypovolemic patient, oftentimes, they are significantly total body volume depletion. They've gotten rid of a lot of their water, but they've gotten rid of a ton of sodium from their body. And that's really what's causing these patients to have this problem. So what we can do is we can categorize these patients in a way of saying that they have a really significant depletion of their total body sodium. So I'm going to put total body sodium, but they also have a depletion in their total body water. So they have more sodium loss though than they have water loss. And then in this scenario, you make them hypovolemic, right? So they're already going to be a little bit loss of sodium more than usual, right? So they have a little bit more water in general. And then you increase their ADH production. It makes them reabsorb more water. You bring in more water on top of the sodium that they already lost. You're going to dilute down their sodium even more. So that's how this whole thing propagates. So let's have an understanding here of the two different ways that we can get rid of sodium and a little bit of water from the body. One is you can lose it from the kidneys. If I'm losing sodium and water from the kidneys, how could I do this? There's a couple different ways. One way is I could use diuretics. And if I use different types of diuretics, what are a couple of these? Well, one could be loop diuretics, and the other one could be thiazide diuretics. So what are your loop diuretics? This is going to be furosemide, torsemide, bumetanide, all of those guys, right? What are they blocking? We'll represent it right here. It's in the ascending limb of loop of Henle. You block the sodium potassium 2 chloride cotransporter. Can you reabsorb sodium, potassium, chloride, and water? No. Where do you lose it? You lose it in the urine. So what do they lose? They lose a lot of sodium and water in their urine, but more so sodium than water. So they're gonna have lots of sodium loss in their urine, but they will have some water. What's another diuretic? Thiazides. And believe it or not, these actually cause more hyponatremia than loop diuretics would. How do they do this? They block the sodium chloride symporter present in the distal convoluted tubule. Can you reabsorb sodium here? So I can't reabsorb sodium here. I can't reabsorb sodium here. So where do you lose it? You lose it into the urine. And what else do you lose? Water. So again, in both of these scenarios, you're losing water, but you're losing more so sodium. All right. What else? Another scenario is you could have low aldosterone. You're like, low aldosterone? How is this coming into play, Zach? What the heck? You know, there's a renal tubular acidosis we call for this one. It's called RTA type 4. There's a lot of different reasons why this happens, right? One is honestly could be to adrenal damage. So you could have adrenal insufficiency. That truly could be one reason. We'll represent that as AI. Another one is you could be using drugs. ACE inhibitors, ARBs, all of these suppress aldosterone indirectly, right? And what happens in these particular scenarios is if you have low aldosterone, are you going to be able to reabsorb sodium here at the distal convoluted tubule? No. And so I can't reabsorb sodium here. And so what happens is I lose a lot of the sodium in the water in the urine. So this could be a couple different reasons. There is another one. It's important to remember this. It's believed to be kind of linked here, and it's called cerebral salt wasting. So it's called cerebral, it's believed to be maybe due to a low aldosterone, cerebral salt wasting. And so this is different in the other scenarios, adrenal insufficiency, ACE inhibitors, ARBs. This one, usually you see patients with heavy polyuria. So you'll see two things. One is it's oftentimes they have a subarachnoid hemorrhage, and the other situation here is that they have very, very, very heavy urine output, excessive polyuria. So again, thinking about these patients who have renal causes of hypovolemic hyponatremia, they're peeing out tons of sodium-rich fluid, whether it be diuretics or low aldosterone related states. Okay, cool. So high urine sodium would tell me that this is a renal cause. So what I want you to start thinking of in this particular scenario is if the urine sodium is really high, that means that I'm probably peeing out a lot of the sodium-rich fluid. There's some type of tubular dysfunction going on here, whether it be diuretics or low aldosterone. The other concept that's really kind of important here to think about is that these patients are oftentimes, their blood volume is going to be low, right? We know this because they're depleting it from their kidneys. You're getting rid of a lot of it. In that scenario, what that should do is do what to the kidneys? Activate the renin-angiotensin-aldosterone system. Renin-angiotensin-aldosterone system. And this will help to increase ADH, and it'll also help to increase your aldosterone levels. Problem is that in this scenario, your tubules, this will help to propagate more water reabsorption, which will lead to hyponatremia. This will try to go and reabsorb more sodium. But because all the tubules are being blocked by diuretics or a low aldosterone state, this won't properly work in renal causes. And that's why the urine sodium will be really, really high in these scenarios. Okay, let's come over to the extrarenal causes. What's another way that we can lose fluid from the body, sodium-rich fluid that's not coming from the kidneys? Well, you could be losing it from the GIT. So we can have GI losses. What are a couple different ways that we can lose sodium-rich fluid? Well, vomiting, diarrhea, and even I would say to some degree poor intake. So I would say vomiting, diarrhea, and decreased PO intake, so oral intake. These could be a couple different reasons why you're losing sodium-rich fluid from the body. Another one is you could be losing it from the skin, believe it or not. So this one's interesting. So skin losses, this actually could be due to a lot of sodium-rich loss from the cells or from your sweat glands. So what if I destroy some of the cells and I release a lot of the sodium-rich water from my cells? What could do that? Burns. So severe burns. You know another one? Another one is diaphoresis. So excessive diaphoresis. What the heck is that, Zach? Sweating. So you're sweating like a banshee. Oftentimes you see this in patients with severe fevers. So if you have uncontrolled fevers, you can really lose a lot of sodium-rich fluid via sweating. Okay. Via these mechanisms, I'm depleting my blood volume. Right? I'm getting rid of sodium-rich fluid from my body. So as a response, my blood volume will drop. All right. If my blood volume drops, what does that do to the kidneys? Helps to activate the renin, angiotensin, aldosterone system. So now this puppy is going off. And what is it going to do? Increase ADH, which will do what? We already know. Increase water reabsorption, precipitate hyponatremia. But the other thing is that it's going to activate that aldosterone. When you increase aldosterone, what does that do to the kidney tubules if they are not being dysfunctional? Meaning there's no diuretics on board, there's no low aldosterone states that are occurring. Well, if the kidneys are functional, it'll go to the kidneys and it'll help to reabsorb a lot of sodium. If it reabsorbs a lot of sodium, it's doing that to try to replenish your blood volume and the sodium-rich fluid loss that's occurring. But what happens to the urine sodium? The amount of sodium that's present within the urine drops. Now, do you see how we could have a test that if the urine sodium is high, it's coming from the kidneys? If the urine sodium is low, it's coming somewhere else. Isn't that cool? All right, that tells us about the hypovolemic patient. So in these patients, they're going to be volume depleted. Look for decreased skin turgor, look for dry mucous membranes, look for low blood pressure, tachycardia, and even potentially in these patients, you have no evidence of any edema. All right, euvolemic hyponatremia. In a euvolemic patient, it means normal. So in other words, when you look at their total body water and their total body sodium, they have just a teensy bit more total body water relative to the total body sodium. So they're just going to have just a teensy bit more water than they will sodium within the body. So in these particular situations, really the only thing that's happening here is that the body is inappropriately producing ADH. That was an appropriate production of ADH because it was low blood volume, low blood pressure. In this situation, the patients are usually euvolemic. Their blood volume is normal, their blood pressure is normal, so they're not producing ADH for that reason. What would be a reason we would produce ADH? Well, the pituitary is either pumping out a lot of ADH without any blood volume or blood pressure stimulus, or I have a tumor, a malignancy of sorts, that is pumping out high levels of ADH. And then when this is happening, we already know that high levels of ADH is going to do what? It's going to come down here, act on the V2 receptors, and increase water reabsorption. And as a result, I'm going to bring in more water than I will have relative to sodium. I'm not losing sodium technically in this particular situation. So I'm bringing in more water, which is going to dilute down my sodium. Okay. Question is what in the heck is causing this inappropriate ADH production? Because this is really how we would define this. This is SI-ADH. It's the inappropriate production of ADH without a proper stimulus. So then we have to start thinking, what are some causes? What are some SI-ADH causes? And there is a plethora of them. And that's what kind of makes this challenging when you think about it. One is it could be you have some type of CNS injury. So some type of CNS injury. So what are some CNS injuries or dysfunction that I would really think you guys, or urge you guys to consider? Well, one is have they had a recent stroke, right? So in this particular situation, have they had a CVA, a cerebrovascular accident, whether it be ischemic or hemorrhagic? Has there been any type of traumatic brain injury, right? Another thing is you want to think about pulmonary diseases. So hypoxia is a very, very weird stimulus of ADH production. And so things that cause hypoxia, so pneumonia, ARDS, maybe severe COPD, so pneumonia, COPD, ARDS, these things also have a very potent stimulus for ADH production. Drugs tend to be very profound stimuli as well. And so a couple different drugs that are usually worth remembering here is going to be particularly in the vicinity of SSRIs, so selective serotonin reuptake inhibitors that we use for depression and anxiety. As well as another very important one would be carbamazepine, which is an anti-epileptic, carbamazepine. The other thing that I would want you guys to remember is malignancy. So malignancy is a very, very profound stimulator as well. Usually it's via paraneoplastic syndrome. So the tumor itself gains the capacity to produce ADH, not the pituitary. These things are all stimulating the pituitary. So here I'm going to put this as stimulating the pituitary, stimulating the pituitary, stimulating the pituitary. This one is not necessarily stimulating the pituitary. It's the mass itself, right, that's producing the cancer. You know what the most common cancer is that we usually see associated with this? It's usually small cell lung cancer. And this is the tumor that's actually gaining the capacity to produce ADH. The last thing is we actually sometimes group it into SIADH, believe it or not, and it's endocrinopathies. So endocrinopathies of some sort that can kind of mimic SIADH, but you have to rule these out before you can make any of these other assumptions. And the two that are worth remembering here is going to be adrenal insufficiency. So adrenal insufficiency, so you have to check their cortisol levels. And the other one is hypothyroidism. So truly, before you can make the true definition of these related causes of SIADH, you have to rule out adrenal insufficiency, low cortisol, or hypothyroidism, low thyroid hormone. These are the triggers for SIADH. SIADH leads to increased water reabsorption. Now, I put it in the renal causes category, and I want you to understand why. It's very interesting. Because they're reabsorbing water and there's no volume loss, in these patients, their blood volume is, what do we say? Normal. And if you really want to think about it, you could say normal to slightly elevated, just slightly. As a result, what is that going to do to the renin production by the kidneys? And it's going to suppress it and it's going to appropriately suppress it. So in this particular scenario, what would happen to the renin-angiotensin-aldosterone system? It would be appropriately suppressed. So the aldosterone levels will be appropriately low. If the aldosterone levels are appropriately low, what will that do to the kidneys? Will it reabsorb sodium? No. And so as a result, what happens to the sodium? So we'll kind of represent it like this. What happens to the sodium? Will I reabsorb it? No. And so the urine sodium will be high. And that's why we say that the sodium will be a little bit higher in the urine, and that's why we classify this as a renal cause of euvolemic hyponatremia. So again, for this one, I want you to remember that if the urine sodium is high, then this is likely a renal cause. Think about SIADH. And what are the reasons? CNS, pulmonary, drugs, malignancy, but you have to rule out endocrinopathies first. If the urine sodium is normal, all right, let's say it's not in this situation high, it's normal, then we have to think about extrarenal causes. This is the weird one, all right? In this situation, there is a couple different reasons why this can occur, but the two big ones is that the solute intake is low, or that the actual water intake is insanely high. Whoopsie, this should be upwards. So its solute intake is really, really low, or the water intake is crazy high. So if I have a crazy, crazy low solute intake, means I'm not taking in enough the electrolytes within my diet. And my water intake, as a response here, is really, really high. What am I doing to my circulatory system? I'm filling it with tons of hypotonic fluid. So now my volume is pretty good. All right. So now here I can say that my blood volume is pretty good. It's pretty normal. If anything, it might even be a little bit pumped up in kind of this scenario. But I'm filled with water. All right. There is a lot of like hypotonic fluid inside of my circulation. As a response, what is my kidneys going to try to do? It's going to do its best to try to dump a lot of that water out into the urine. And so it will kind of produce a very, very, very dilute urine. All right, so I'll have a lot of water, a lot of water that's going to be present in the urine, right? And so what does that mean? That means the urine osmolality is going to be very low, right? That was those ADH independent causes. So I'm going to do my best, but no matter how much water I try to be able to excrete out of via the kidneys, there's too much high water intake or very little solute intake that no matter what, the blood that's actually leaving the glomerulus and coming out, I'm still going to have too much water in my system. So no matter what, there's still going to be too much water remaining in my circulatory system. And as a result, this will drive down my sodium. So then you have to ask yourself the question, okay, what are the things that I'm either taking in so much water that my kidneys can't excrete enough of it, or what are the things that causes a very low solute intake where now I just have more water in my circulation with respect to low solute? There's two reasons. One is this can be due to what we refer to as a tea and toast diet. So the tea and toast diet. Or another one is it could be beer potomania, where patients are just drinking very large amounts of beer, or they're just drinking a lot of fluid and not getting a lot of solute within their diet. The other one is excessively high water intake. And this is usually in the disease that we refer to as primary polydipsia. We see this in schizophrenic patients who drink tons of water, or fraternity hazings. Another really common one that we see in the hospital a lot of the times is the patients are just getting too much hypotonic fluid, so half normal saline, lots of water, things like that that could actually also dilute down their sodium. All right, that covers, in this particular scenario here, all of the hypovolemic and euvolemic causes of hyponatremia. Let's now talk about the last one, which is hypervolemic. Let's talk about the last type of hyponatremia, which is hypervolemic hyponatremia. So in this particular scenario, these patients are very volume overloaded. And so oftentimes what we say for this is that they're going to have a very, very large amount of total body water, right? So there's a lot of fluid that's leaking in between their interstitial spaces, in their cells. And so usually they have a very heavy total body water. But they also, when you look at them, they have a little bit more sodium within their body than other people usually do. And it's usually leaking into their interstitial spaces or into their cells. And so what happens is they also have a very slightly increased total body sodium. Now, in this particular scenario, if we have a very high amount of total body water, and again, a little bit more total body sodium, this is what we would see in these patients. They're usually very edematous. So they have maybe a lot of peripheral edema in their legs. They also may have ascites. They may have pulmonary edema. So when you auscultate, you may hear rales on auscultation. They may even have a very distended or plethoric jugular vein. And on top of that, usually these patients, they gain a little bit more weight easily, so they're a little bit more fluid overloaded. Their blood pressure might be a little bit more elevated as well. All right, oftentimes though, they have good mucous membranes, good skin turgor. So when we talk about these patients, because they're edematous, right, what are the things that we want to think about? You want to think about diseases that retain fluid, right? And oftentimes that's CHF cirrhosis and CKD. So let's talk about the extrarenal causes, which includes CHF and cirrhosis. How do these really cause this? Well, in patients who have CHF, they have some type of dysfunction of their myocardium, which impairs their cardiac output. So what happens to their cardiac output? The amount of blood that they're pushing out of their ventricles into the aorta or into the pulmonary trunk is reduced. So either way, in these particular scenarios, they have a very, very low cardiac output. So this would be the primary pathophysiological process here in CHF. So in patients who have CHF, they have a reduced cardiac output. Why is that a problem? Why is the reduced cardiac output a problem? Well, if you think about it, reduced cardiac output leads to a reduced amount of blood that is circulating within our arterial circulation. So what we say is they have a reduced effective arterial blood volume. That is what's reduced. So if that's reduced then what we can say is the amount of blood circulating through their bloodstream is technically low. So they have a low effective arterial blood volume. What would the JG cells sense? They would sense a low blood volume, a low perfusion to their kidneys. As a response to that, what will they release? Renin. Renin will lead to the increased formation of angiotensin II as well as aldosterone, ADH. So as a response here, what are we going to get? We're going to get a hyperactive renin-angiotensin aldosterone system. And then you're going to get a high ADH. As a response here, what is that going to do? Go to the kidneys, reabsorb water. What else is going to happen? Well, the other thing that's going to happen is I'm going to lead to more aldosterone. And if I lead to more aldosterone, what does that do? That goes to the kidneys and helps to reabsorb sodium. So if I go to the kidneys and I reabsorb more water via ADH and I reabsorb more sodium via aldosterone, what happens to the sodium that's present in the urine? It's going to be low because I reabsorbed it. So I'm stimulating these processes, and now my amount of sodium that is present within the urine is going to be low. That's how we remember. Extrarenal causes, usually they have a low urine sodium. The ADH brings more water, and then what happens is in these patients, they're going to have more water in their circulation. They also have lots of water and sodium sitting in their interstitial spaces. So when you look at these patients, they have lots of sodium sitting here. Very little sodium in their circulation, and then they have lots more water in their circulation and lots of water in their interstitial spaces. And that's what makes these patients what we refer to as hypervolemic. They have more volume in their interstitial spaces, not as much volume in their circulatory system, their arteries and veins. Now, with that being said, we understand how this leads to increased water reabsorption, diluting the sodium, and we cause increased reabsorption of sodium while the urine sodium is low. How does cirrhosis do this? Cirrhosis is a kind of interesting one. So cirrhosis, in patients who have very, very severe cirrhosis, they undergo lots of fibrosis of their liver, and this fibrosis leads to a reduction in hepatic synthesis, but it also leads to compression of the hepatic portal veins. And then the pressure builds up in this portal vein. What do we call that? We call this portal hypertension. So they start developing something called portal hypertension, where the pressures in their portal circulation are high. What happens is the liver releases some chemicals, the little vasodilators. And what these vasodilators try to do is dilate the actual splanchnic, the circulation that goes to our GIT. So it tries to undergo something called splanchnic vasodilation. What this does is, now watch this, here's our circulatory system. It goes here and it causes these vessels, let's say that are going to your GIT. This is going to your GIT. It dilates them. And now what I do is I pool lots of blood to my GIT, which leaves very little blood to go where? Through the systemic circulation other than my GIT, especially to my kidneys. My kidneys sense a low effective arterial blood volume. What do as a response to that? They release renin. So then we pump up the renin, angiotensin, aldosterone system, and we get the same thing that we just talked about here. Increase water reabsorption, bring more water in the circulatory system, dilute down the sodium, and then aldosterone goes and tries to reabsorb some of the sodium and bring it into your bloodstream, which makes your urine sodium low. Now, there's one other mechanism, and this helps to explain the edema factor, where your liver struggles to produce an adequate amount of a very specific protein called albumin when it gets destroyed. If albumin is low, albumin is supposed to be a very potent osmotic agent. So imagine here is these black dots are albumin. They're supposed to keep water into the bloodstream. What do? If you don't have enough albumin, are you going to be able to keep the water or pull it into the bloodstream? No. And so all of this is inhibited, and guess where the water stays? Out here in the interstitial space. What happens now to the amount of volume in your bloodstream? It goes down. So what does that do to your effective arterial blood volume? It drops it. So there's a twofold process in cirrhosis and how this causes hyponatremia. Splanchnic vasodilation and hypoalbuminemia. Whew, all right. Now, obviously this can be elucidated via history. The last one is also elucidatable via history. But if you really needed to, you could check a urine sodium. Urine sodium in these are going to be low. The urine sodium in this one should be high. Again, this last cause would be chronic kidney disease. At least at the point of where these patients are like stage 4, 5, or they're on hemodialysis. So we get to the point where we're calling them almost end-stage renal disease. Usually what has to happen is these patients usually need a GFR at least near less than or equal to 15 milliliters per minute. So as their GFR is really, really significantly low, what happens is, let's say here I have some water, right? So here's some water. Patients are drinking water. Their kidney can only excrete so much water because they have very little nephrons. We've destroyed tons and tons and tons of nephrons. So they have very little nephrons available. This water is supposed to move through the circulatory system. It's supposed to be filtered out. And then eventually, we're supposed to pee this water out. But the problem is that the kidney stinks at doing its job and it's not able to properly excrete the water. So what happens to the amount of water that we excrete? It is very, very low. So we bring in lots of water for this patient, but their kidneys aren't able to excrete the water because they have very little nephrons available. What happens to the amount of water that's leaving the glomeruli then? Unfortunately, they're going to have way more water. So if I have increased water that's present in my circulatory system, what's that going to do to my sodium? That is going to bring down my sodium. But here's what's really interesting. If I have lots of water, what is that going to do to ADH? It's going to suppress ADH. So remember, this suppresses ADH production. So ADH suppressed states could be what diseases? It could be due to beer potomania. It could be due to the tea and toast diet, primary polydipsia, or patients with end-stage renal disease. One more concept. So if I have low, or let's say suppressed, let's actually just for the simplicity's sake, let's say low ADH. The reason why they have hyponatremia is because they aren't able to excrete enough water from their kidneys. What happens to this situation here? Well, if they have lots of water, then we say that their blood volume should be appropriate then, if anything. So their blood volume should be appropriate. If it's appropriate, right, because if we think about this, they have a lot of water in their circulation and it's diluting down the sodium. What happens now? If their blood volume's normal, what's that going to do to the kidneys? It's going to tell the kidneys, hey, don't release renin as much. Don't lead to the formation of angiotensin and aldosterone as much. So now the RAS system should be suppressed. So what happens to aldosterone? It should be low. If aldosterone is low, is it going to be able to reabsorb the sodium across the actual DCT? No. And since aldosterone struggles at this area to try to be able to reabsorb sodium, it won't do that. The sodium will get lost into the urine. So what happens to the sodium in their urine? It goes up. And so the sodium in their urine is up. And so that's why you have high sodium in their urine. So again, renal causes, you have to remember, they will have a high urine sodium. All right, I know this was a lot. Hang in there with me, and let's now move into the next step, which is hypernatremia. All right, my friends, so now we're gonna move on to hypernatremia. So it's the other end of the sodium disorders when the sodium is way too high. Greater than 145 is generally what we kind of define that as. Now, when a patient develops hypernatremia, the pathophysiological mechanisms are listed over here. It's usually the exact opposite. So in hyponatremia, usually the patient is just pumping out tons of ADH, reabsorbing a lot of water, diluting down their sodium. And the opposite situation here is one of the most important ones to remember. We can see that there's a decreased ADH release. So usually we define this as something called central or nephrogenic DI. So let me explain these two. In central diabetes insipidus, The problem is that the posterior pituitary, the hypothalamus in some way, shape, or form, is not adequately producing enough ADH. So the ADH levels are usually deficient, right? And we'll go over this a little bit more later when we get into the subcategories of hypernatremia, hypo, euvolemic, and hyper. But if the ADH is low, what happens? Well, then it doesn't hit the V2 receptors appropriately, right? And if I don't hit these V2 receptors appropriately, am I going to increase the expression of aquaporin subunits? No. Am I going to be able to reabsorb water across the lumen cells and into the blood? No. So I lose a lot of water into the urine. Another thing is for nephrogenic diabetes insipidus, these receptors are the problem. So in nephrogenic DI, these receptors are not appropriately responding to the ADH. So the ADH could be present. It could be in high amounts. It won't matter. It's not going to respond. So there's no response. Are you going to be able to express these aquaporin subunits? No. As a response, are you going to be able to reabsorb water? No. So as a response, I get decreased water reabsorption into the bloodstream. If I get decreased water reabsorption, what happens to the relative concentration of sodium? It'll start to go up because I'll start concentrating my blood as I lose more water from the vascular system. Right? It's straightforward. And again, the concept here is because we are inhibiting the expression of aquaporin subunits. And as a response, I lose tons and tons of water into the urine. What does that do to the osmolality of the urine? Well, it's super dilute now. So the osmolality of the urine is going to be very low. And this is usually pretty much indicative of a patient who has something called diabetes insipidus. Now, with that being said, if I see a patient who has a very, very dilute urine, I send it off to the lab, and when I check it, I see a very, very low urine osmolality. Generally, we say like less than 600, all right? Usually 300 to 600, it's pretty low. In that situation, I could definitely think about diabetes insipidus. The other scenario that I want you guys to think about is what if the aldosterone levels are too high? If aldosterone levels are too high, there's a couple different reasons why that could happen. But the biggest thing here is when your adrenal cortex, for whatever reason, is pumping out tons of aldosterone. Maybe it's because there's a stimulus, a secondary stimulus, or maybe there's a tumor of the adrenal cortex that's pumping a lot of aldosterone out. Either way, there's a lot of aldosterone. When I have a lot of aldosterone, what is the problem with that? Why is that a significant issue? Well, let's imagine here. Let's say I have high amounts of aldosterone. We'll represent this with kind of this blue dot here. It gets into the cell, right? It's a steroid. So what it's going to do is when it gets into the cell, it activates a receptor, increases the expression of these guys. So it increases the expression of these ENaC channels. If I increase the expression of the ENaC channels, what am I going to do? What am I going to reabsorb across this cell? I'm going to pull tons of sodium across the cell. So I'm going to increase the expression of the ENaC channels, which is going to increase sodium reabsorption, but it'll also bring a little bit of water. Oftentimes in aldosterone release states, when it's high aldosterone, you're going to increase your sodium and water reabsorption, which is going to pump up your blood volume, which is going to pump up your blood pressure. And so that's one really, really important thing to remember is that oftentimes these patients are slightly hypervolemic and hypertensive. And it's a very common cause of secondary hypertension. So please think about that. So in a patient coming with excessive polyuria, think about DI. And a patient coming in who is hypertensive, hypervolemic, edematous slightly appearing, start thinking about hyperaldosteronism. There is another one that you want to think about. We'll talk about a little bit later, but I want you to start having a differential diagnosis. And the differential diagnosis that you have to start considering in these states is sodium chloride containing solutions. So is a patient getting a lot of sodium chloride solutions? Are they in the hospital? And in the hospital, are they getting a lot of isotonic saline, hypertonic saline, bicarbonate, TPN? All of these things can also create a hypervolemic, hypertensive, and hypernatremic state. All right. Last scenario here is when a patient is losing a lot of water from their body and they're not just drinking enough water back in. They're not bringing it back in. So let's say I have a patient who's peeing out a ton of water. So they have lots of renal losses, right? Tons and tons of water that they are losing here. Or they got a punami going on. they're dropping turds and it's just filling up the bowl with water, or they're vomiting out a lot of water, right? So in these particular scenarios, what am I doing? I'm losing water from a renal source, or I'm losing water from an extrarenal source, maybe from the GIT, maybe from the skin. So we're gonna call this extrarenal losses. And we'll get into the different types a little bit later. But in this scenario, I'm getting rid of a lot of water. It's not from, it's from either the GIT, the skin, or the kidneys. So as a result, am I reabsorbing enough water from the kidneys? Am I absorbing enough water across the GIT? Am I retaining fluid inside of my skin cells? Well, in this particular situation, no. And so what starts happening to the water inside of the bloodstream? It starts going down because I'm not absorbing or reabsorbing things appropriately. So as water starts getting lower, what happens to the sodium concentration inside of the bloodstream? It resultingly goes up. So now I have a patient who is hypernatremic. What would this do? Well, generally, when your water goes down and your sodium goes up, what it's supposed to do is activate your thirst centers. So it's supposed to activate your hypothalamic thirst centers and make you drink water. If I drink more water, what will then happen? Hopefully, I'll bring up my water concentration and dilute down the actual sodium. So what's supposed to happen, the normal pathway, what's supposed to happen is I'm supposed to stimulate my thirst centers, right? Which is in the hypothalamus. And then as a response to that, I should increase my water consumption. And the whole purpose of that is that I'll bring more water into the body. So this is the normal physiological response. But what if I have a patient who's losing water from the GIT, skin, or the kidneys, but the problem exists right here is that they will not increase their water consumption. So this is where that a problem exists. So in a patient who has maybe renal losses or extrarenal losses, this is what's leading to a decrease in our serum water. So this is what's dropping their serum water, right? But then what are they supposed to do? Become thirsty, drink. What if I have a patient who has a decreased water intake? If I combine both of these, the problem with this is I'm just gonna be doing the same thing. I'm perpetuating this process here. I'm not getting enough water back into the circulation. What are some reasons why a patient won't drink enough water? Well, oftentimes it's because they have something going on, such as, let's say they're intubated. They have a tube in their airway, so they can't tell somebody that they're thirsty or they're sedated. Another one is they could have some type of altered mental status. Or elderly individuals, sometimes geriatric patients is a very common population that we see this in. And the last one is maybe decreased or limited access. So maybe you have a limited access to water for some type of socioeconomic reason or whatever it may be. But this combination, if you will, is what we see most often as the cause of hypernatremia. Most likely hypovolemic hypernatremia, hypervolemic hypernatremia, and euvolemic hypernatremia. Let's go through that now. All right, my friends, let's now go through each type of hypernatremia based upon volume status. And again, this is super important just in the same way that we talked about it with hyponatremia. You're assessing the patient to look, or do they have decreased skin turgor? Do they have dry mucous membranes? Are they hypotensive, tachycardic? Do they have some of these features without any edema present? What way are they losing water? And oftentimes it's pretty simple. If the patient says that I've been peeing a ton, that's oftentimes pretty elucidative of the cause. But another way that we can kind of look at this is in a patient who has hypovolemic hypernatremia, what we really want to do is understand something called, where's the water being lost, and we can do that off of urine osmolality helpfully, but also history. So let's say that we think about some renal reasons why a patient would be losing tons of water. So here, they're losing a lot of water in their urine, all right? If I lose a lot of water in the urine, that means that the urine is very dilute. If the urine is very dilute, then what that tells me is that the urine osmolality would be what? It would be low because I have a very dilute urine. It's not a very concentrated urine. And so that's relatively helpful right away. And so one of the things I can tell myself is if I check a urine osmolality and it's lower, it could be indicative of DI, diabetes insipidus, or a renal cause related to hypovolemic hyponatremia. The way that I would want to do this is in a patient with DI, they appear euvolemic. They don't appear to be volume down in the sense that they don't have decreased skin turgor. They don't have any types of dry mucous membranes or hypotension, tachycardia. In these patients, they appear euvolemic. In this patient, they definitely appear to be hypovolemic. So what would be some reasons I would lose a lot of water across the kidneys? Well, it's usually a simple thing such as osmotic diuretics. And the two that I would really want you guys to, strongly remember here is going to be mannitol and hyperglycemia. So in the history, it's pretty evident if a patient received mannitol, why in the heck would I give somebody mannitol? The reason I would give somebody mannitol is did they have an ICP issue? So as mannitol is often given to help to reduce the intracranial pressure. So if someone had any kind of recent intracranial pressure issues, that I'm giving them mannitol for. Another one is in patients who are diabetics who have very high glucose levels. The reason why this is important is whenever you have very, very high glucose levels, glucose acts as an osmotic agent. And imagine here now, mannitol glucose, I represent them as these black dots here. They're going to be moving through our tubular system, and if you have a lot of these agents, they're super osmotically active, guess what they're going to do? They're going to yank water with them. And all of this water is going to get yanked into the actual urine. So these are exhibiting an osmotic type of effect. So again, if a patient has a very high glucose, think, do they have any underlying disease like diabetes? So glycosuria and the mannitol use are very common to cause excessive polyuria, but very watery urine output. And that would cause volume depletion in that particular scenario. An extrarenal cause, in this situation, we're thinking about, okay, there's a GI loss or there's a skin loss. And believe it or not, this is exactly the same to hyponatremia. The only difference is in this patient, they're going to lose a lot of water from their kidneys, and guess what? They're not going to drink the water at all, and because they don't drink any water, their water intake is reduced, they're going to perpetuate their hypernatremia. Same thing, if they're pooping, vomiting, or having excessive diaphoresis and burns, and they're not drinking water, they're not repleting back the water that they're losing. So in patients who have very, very terrible, let's say, for example, this patient could be diarrhea, it could be vomiting, or it even could be excessive NG tube suction. In this scenario, it could be excessive diaphoresis, so they're sweating like crazy, or it could be severe burns. In these particular scenarios, what you really want to remember is something very interesting. They're losing a lot of water from areas that are not the kidneys. So because of that, what happens? All right, watch this. In this scenario, both of these patients, they're losing volume. All right, so they're going to lose volume. We're going to go down the extrarenal cause. So if you lose blood volume because you're pooping it out, vomiting it out, or you're having it lost from your skin, what is that going to do to your kidneys? It's going to tell the kidneys that the perfusion is low. If it tells the kidneys that the perfusion is low, what's that going to do? It's going to activate your renin-angiotensin-aldosterone system. If you activate your renin-angiotensin-aldosterone system, what should that do? That should go and activate ADH. If I increase ADH production, what will that try to do? It'll try to go to the kidneys and retain water. So if I try to go to the kidneys and retain water, what happens to the amount of water that's present in the urine? There's less water in the urine. What happens to the urine osmolality? It goes up. And so in these patients, they have a very high urine osmolality. That's helpful. So look, high urine osmolality and extrarenal causes, low urine osmolality and renal causes. And that's super important to remember. This kind of process occurs here. The same thing, where they'll have low blood volume. You'll activate the renin-angiotensin-aldosterone system, but it won't matter because you're continuing to lose water. So that's one of the big things that are helpful here. All right, so euvolemic hypernatremia, in this particular scenario, it's two particular processes that are occurring here. It's either I'm not making or releasing ADH, or I'm not responding appropriately to the ADH. So remember I told you that this one, if there's damage to the hypothalamus, posterior pituitary, what happens? Are you able to produce and make ADH as a response here? No. So what happens to the ADH levels in this patient? It's low. If I have low ADH, we already know all of this. We don't really need to go crazy on this. We already understand that what this will do is this will go to the kidneys, and you're going to lose a lot of water into the urine, right? Straightforward. The question that you need to ask yourself is what's causing this? And this is a disease that we refer to as central diabetes insipidus. So central DI. And oftentimes, this is usually due to maybe a traumatic brain injury. So I think traumatic brain injuries are definitely big things to remember. Another one is, I would say, some type of surgical procedure that is in the vicinity of the hypothalamus, the pituitary. Sometimes we even see these after patients have removed the pituitary adenoma. And the last one is, I would say, what's called brain herniation. So when a patient goes unfortunately, they experience herniation onto their brainstem, this is another presentation which we see in central DI. All right, so in this problem, it's that they're not making ADH. So the kidneys have appropriate receptors, so they would respond to it, but they don't have enough ADH. This one, this puppy is pristine. He's looking good. So in other words, this hypothalamus, posterior pituitary, they can pump out ADH like it's no other. All right, so it's working well, right? So I can make ADH if I really want to. Now, here's where the problem exists, and we already talked about this a little bit. The problem exists here. The problem exists here. These cells, the V2 receptors, are not appropriately responding to the ADH, so they don't reabsorb water, lose a lot of water into their urine. Question comes up is what's causing this? We call this one nephrogenic diabetes insipidus. And this one, we see the most common offenders to be the use of lithium in bipolar disorder. That's one really, really big one. So look in the history to see if they're taking any lithium, maybe even check a lithium level. Another one is potassium and then calcium. So it's the opposite. Whenever calcium is extremely low, this can cause nephrogenic DI, and whenever calcium is really high, it can also cause nephrogenic DI. Either way, both of these, they present very, very similarly, where they're going to lose a ton of water into their urine. So the urine osmolality in both of these situations here, I'll bring it over here just so that we can remind ourselves, is going to be what? It's a very, very low urine osmolality. So it'll appear somewhat similarly in what situation? To the hypovolemic hypernatremia that we see with renal losses. Big difference here is that this is a euvolemic state, that's a hypovolemic state. All right, let's move on to the last scenario, which is hypervolemic hypernatremia. All right, friends, last one, which is hypervolemic hypernatremia. So in this patient, we had, again, hypovolemic, their volume down. Euvolemic, they appear perfectly normal, all right? The hypervolemic patient are overloaded, all right? And what we say is that in these particular patients, they have just a lot more sodium than they do water. The euvolemic patient, usually they have a little bit more sodium than they do water. And the hypovolemic patient, they have been significantly depleted of water and a little bit less depleted of sodium. So let's think about, again, in hypervolemic hypernatremia, the patient's problem is usually that their aldosterone levels are way too high. Now, aldosterone release is kind of a variable thing. So for example, I can have something called primary hyperaldosteronism. So primary hyperaldosteronism. So this is usually a tumor or hyperplasia of the actual adrenal cortex. And in this particular scenario, it is pumping out high levels of aldosterone, right? So oftentimes, more than not, it is usually some type of tumor, such as an adenoma. It also could be in certain scenarios like hyperplastic tissue as well. But either way, it's the adrenal cortex that is the problem. And in this scenario, it is pumping out way too much aldosterone. Another scenario is it could be what we refer to as secondary hyperaldosteronism. And in this scenario, it's really, there is an influx of stimulation to the JG cells that are pumping out tons of renin. And what you have to know is that renin leads to the formation of, eventually, angiotensin. And so if I activate my RAS system, thus the name, when I activate the RAS system, I'm naturally going to stimulate, via angiotensin 2, I'm going to stimulate the production of aldosterone. The primary stimulator for secondary hyperaldosteronism is usually low renal perfusion. We talked about this more in the endocrinology section, but you can see this in things like CHF, you can see this in cirrhosis, you can see this in renal artery stenosis, but either way, these things are stimulating the RAS system, which is increasing aldosterone production. So again, I wouldn't, put all your money on it, but think about CHF, and think about renal artery stenosis, and think about cirrhosis as potential triggers here for secondary hyperaldosteronism, or think about a tumor. Either way, aldosterone's high. All right, cool. What does high aldosterone really do? Well, if I got high aldosterone, remember this is a steroid hormone. Some people even say that Cushing syndrome, because it kind of has a little bit of a mineralocorticoid activity, can also act like this, but I don't want to take you guys too far on that. But what this is going to do is this is going to come in, it's going to activate your genes, and it's going to increase, not your Wrangler genes, I'm talking about like actual DNA genes, but it's going to increase the expression of ENaC channels. If I increase the expression of these ENaC channels, then what I'm going to do is I'm going to move more water across the distal convoluted tubular cells. Sodium. I'm going to move more sodium. And then a little bit of water oftentimes follows. So I'm going to increase the expression of ENaC channels, which increases the reabsorption of sodium, and a little bit of water oftentimes follows into the bloodstream. Do you see how that directly causes hypernatremia? But again, if I add in, we're going to make this a little bit of a comparison here. We'll just do one of these guys here. One water molecule. The combination of all of this is going to do what? Is going to increase the blood volume. And if I increase my blood volume, what will I do to my blood pressure? I'll increase my blood pressure. And so oftentimes these patients will present with hypertension, hypervolemia, but there's one other thing aldosterone does. Aldosterone also increases the expression of channels that help to put potassium into the urine. And so that's another thing that you want to watch out for, is you want to watch for them to lose a lot of potassium into the urine. And sometimes they even lose a lot of protons into the urine. But the big thing that I think is helpful here and differentiating these is that if I dump a lot of potassium into the urine, what happens to my potassium in the bloodstream? It drops. So hypokalemia plus hypernatremia plus hypertension, think about high aldosterone states. The last thing I will say is, again, hypervolemic hypernatremia, high aldosterone definitely is one of those that you have to remember, but don't forget what I told you about the differential diagnosis. If I take a patient and I have here a bag of a solution that is super salty, and I just take this solution and I dump it right into their bloodstream, all right? And I have with it a lot of volume. In there's volume, right? So it's gonna have water, it's gonna have a lot of other things, but it's gonna have a heavy amount of salt. If I take and push that sodium right into the bloodstream along with volume, like water, then what is that gonna do to my sodium? It's gonna pump it up, but it's also gonna pump up my water. So you have to watch out for iatrogenic causes of hypervolemic hypernatremia that we oftentimes see in the hospital setting, which again is which one? The big one is going to be an increased use, iatrogenic use of sodium chloride solutions. And what are things that I want you guys to remember? Well, one could be 0.9% normal saline. Another one could be what's called hypertonic saline. There's 23%, 3%, and the other one is we call this bicarb. So we oftentimes call it hypertonic bicarbonate. And even TPN to some degree has a lot of sodium in it. So if you give a lot of these things, which we see in like a neurocritical care units or hospital units, this can definitely increase the sodium, and because you're giving them volume, increase their volume. But they shouldn't have, to some degree, this hypokalemia. All right, my friends, that covers the pathophysiology, the causes, a lot of this on the sodium disorders. Let's now talk about why these are so bad. All right, my friends, so now we're going to talk about the complications of hyponatremia. We'll do this one first, then we'll talk about the complications of hypernatremia. It is of significant importance that you guys really remember the complications of hyponatremia, though. You're going to likely get a question or experience it at some point in time in the clinical world. So, with hyponatremia, the biggest fear that we see with this is cerebral edema. The concept behind this is actually relatively straightforward. So imagine here I have my bloodstream, and I'm going to use these black dots here to represent sodium, right? Now let's say we have a patient who has normal brain tissue here, right? They should have a relatively equal amount of electrolytes, in this case let's say sodium, in the brain tissue in comparison to the actual extracellular space, which is going to be the vasculature. And so there should be a nice equilibrium, if you will, between the tissues and the bloodstream. But in a patient who has hyponatremia, let's say that the amount of solutes or sodium that they have in the bloodstream is going to be, in this particular scenario, much less in comparison to what they have in the brain tissue. Now, where does water like to move? Water likes to move to areas where there is higher amounts of sodium, higher amounts of solute concentration. So where's it going to want to move? Is it going to want to move from the actual brain tissue into the blood, or from the blood into the brain tissue? I think from the blood into the brain tissue, right? And so what will happen is water will flood into the brain tissue. And as the water floods into the brain tissue, it starts to become edematous and swollen. And as a response, one of the most classic features that we see is that intracranial pressure starts rising. So as the brain starts swelling, the pressure inside of the skull starts rising, because the Monroe-Kelly doctrine says that, again, the skull is a fixed space. So if you have anything like more brain tissue, more blood, more CSF, it's going to make the pressure inside of that skull go up. What are some potential clinical manifestations of elevated intracranial pressure? Well, as intracranial pressure goes up, one of the things that we see is we see some degree of swelling and compression of the brainstem structures. For example, maybe I start damaging some of the structures in the medulla, or compressing some of the centers in the medulla that control emesis, right? And so what starts happening is these patients start experiencing things like nausea and vomiting. The other thing is that whenever you increase the pressure inside of the skull, it starts compressing some of the nociceptors or pain receptors in the meninges. And so I may start stimulating some of these pain receptors, which then leads to what? Increasing pain, which is going to represent as headaches. So I may start seeing very bad headaches. So headaches, nausea, vomiting. Here's where it starts getting a little bit worse. If the swelling is big enough that it starts compressing on the cranial nerves. So imagine this swelling starts getting a little bit bigger, and now I'm compressing on this nerve that goes to the eye. What's this nerve? The third nerve. These patients can start to experience herniation findings. And there's different types of herniation. I think one of the big ones to remember is when a patient has a fixed and dilated pupil. This indicates potential third nerve palsy in this scenario of uncal herniation. So you want to watch out, is there any evidence of uncal herniation? So watch for their pupils to see if they're appearing fixed and dilated, right? So in other words, they're dilated, I shine a light, they don't constrict, which they should. The other thing that I worry about is if I start seeing headaches, changes in pupils, nausea, vomiting, but here's the worst case scenario. Here we have this blue structure that extends throughout the brainstem and controls our level of consciousness. If you start compressing this structure, so we compress the third nerve, we compress some of these meningeal areas here, what if we start compressing the reticular activating system? If I start compressing the reticular activating system, my level of consciousness starts to decline. The patient can go from maybe a little bit lethargic to now you're having to stimulate them. You're having to scream their name, push on them a little bit, squeeze them, pinch them to get them to wake up. So now maybe they're more obtunded or stuporous. Worst case scenario, they could go into a complete comatose state. So you want to watch, are they moving along that spectrum of lethargy to obtunded to worst case scenario? Are they in a coma? Because this is a common presentation. So look for any of these findings, and if this is suggestive of that, oftentimes we need to start treating these patients emergently. So ICP issues is one way. Another thing that starts to happen is that as you start causing swelling of the brain tissue, you agitate the cortex. So the cortex starts becoming really, really aggravated, and if the sodium gets pretty low, it can increase the risk of seizures. So not only am I worried about intracranial pressure, I'm worried about an increased risk of seizures. So these are the real big things that I have to watch out for in these patients who have hyponatremia. Now, with that being said, this doesn't usually occur when the sodium is like 134, right? This isn't going to occur in someone who's had a sodium that's been low for a long time, because the reason why is the brain tissue adapts. The brain tissue has the ability to secrete like idiogenic osmoles, which helps to regulate the movement of water in and out of the cells. So like usually after 48 hours, the brain's adapted and it helps to reduce the risk of edema. It's really these types of events that occur in what type of scenario. So when we worry about symptoms, we worry about it in a couple different scenarios. One is it acute? Meaning, has these symptoms developed in less than 48 hours? All right? Because if it has, the brain hasn't had time to adapt. Second, is it severe? And what do I mean? Is the sodium, when we talk about severe hyponatremia, what I'm talking about is the sodium less than 120? So if I see that, if I have symptoms, and on top of that, so let's say, is there symptoms? All right, so you have symptoms. You want to know, is it acute and is the sodium really low, less than 120? If you have symptoms and it's acute, you need to treat these patients emergently. If it's symptoms and it's severe, less than 120, you need to treat this patient emergently. So you have to know these things, because this is where we will see these ICP issues and increased risk of seizures, is when it's acute and very, very severe. All right, the other complication that we can see with usually patients who have hyponatremia is, let's say that you start off, they have a sodium that's pretty low, right? So let's say, for example, we have this patient here. You start them off, maybe they have a little bit of edema, right? So they have hyponatremia, and then what happens is water is moving into their brain tissue, right? So they're getting a little bit of edema, right? So they have a little bit of cerebral edema as a response of their hyponatremia. Then what you do is you say, okay, I got to treat these patients. And what I'm going to do is I'm going to start giving these patients medication. So what I'm going to start doing is I'm going to start giving them hypertonic saline maybe. And so I'm going to start increasing the sodium levels in their blood, right? As I do this, look what starts to happen. I start rising up the sodium in their bloodstream, giving them hypertonic saline. And when I do that, maybe I just do it way too quickly. And what happens is I'm trying to treat the edema, but I pull way too much water out of the brain tissue. And as a result, the brain tissue begins to shrink. And then eventually, cells start dying. And the area where cells tend to die is the pons. That is the problem. So I'm starting to demyelinate some of the neurons present within the pons. So what we see is in osmotic demyelination syndrome is a patient who has hyponatremia. I treat them by giving them sodium. When I give them sodium and I correct it too quickly, the water will get sucked out of the brain, I'll shrink the brain tissue, the cells will die. What's the problem? At what point do we say, oh, if we go above this, we're really increasing the risk of osmotic demyelination syndrome? Well, the textbooks, again, it can vary from textbook to textbook, but oftentimes what it's been shown from the literature is that whenever you try to increase the serum sodium, and you're trying to do this because maybe they have cerebral edema, maybe they have hyponatremia and you're trying to treat it. If you increase the serum sodium greater than 6 to 8 milliequivalents per liter in a 24-hour period, you increase the risk of causing this cellular shifting, the osmotic shifting, way too quickly. You shrink up, shrivel those cells, crenate them, and cause death to the pontine neurons. This is something that, again, we see in hyponatremia. Now, there is certain patients who have hyponatremia that are more at risk for this. For example, if you have severe hyponatremia, if you have a patient who has hyponatremia that's due to beer potomania, tea and toast diet, those kinds of patients, or cirrhotics, hypokalemics, they're at very high risk and you have to be careful. Or chronic, if it's been greater than 48 hours, you should not aggressively treat these patients. But that's something to remember. Now, in this scenario, it was the result of acute, severe hyponatremia that I developed symptoms. And this is because I have symptoms, I'm trying to treat it, but I overcorrected. What would that look like? Well, oftentimes this process doesn't occur for at least approximately upwards of 1 to 2 weeks. 1 to 2 weeks, they start to develop symptoms. So what would this look like? So one of them would be the corticospinal tracts, right? Now, if I damage the corticospinal tracts, what you guys have to know about these bad boys is that they're supplying a lot of the muscles, right? So they're going to come down, they're going to cross at the medulla, but you're knocking out potentially both of them, and you're hitting the entire pons. So you may lose the upper and lower extremity muscle function. So these patients could develop quadriplegia. So that's terrifying in itself. The other component here is that you got a lot of cranial nerve nuclei here, my friends. So I got, cranial nerve 6, 7, 8, 9. A lot of these supply muscles of the eyes, right? Especially 6, which helps to allow for more of the, particularly the lateral rectus, so your horizontal movement. So you may lose that. You may only really get your vertical eye movement truly. And so these patients may only have that vertical eye movement. But in general, they may have diplopia, so double vision, and only be able to move their eyes vertically. They may have dysarthria and dysphagia, so they may have some of those bulbar symptoms as well. And they may have some dysphagia. So they may have difficulty swallowing, difficulty speaking, difficulty with eye movements, particularly they may only have vertical that's preserved. And then depending upon if they hit the reticular formation, they may even have impaired consciousness. So if you think about this patient can't move, they might have difficulty with their speech, and they might not be able to move their eyes horizontally, only vertically. Oftentimes this can look like a locked-in state. And so this is one of the terrifying things about this disorder. That's why whenever you're treating a patient who has hyponatremia, you really don't want to exceed this in a 24-hour period. Obviously your goal is to try to get their sodium up to stop them from seizing or to reduce their ICP. Once you're doing that, bring that sodium back down so that you don't increase the risk of them developing a couple weeks later osmotic demyelination syndrome.
When we talk about this, we're going to put everything together now. Patient comes in, they get a sodium less than 135. If they do that, you get a serum osmolality. All this is doing is looking at the bloodstream and looking at how the tonicity of the bloodstream is appearing. So if I get that and it comes back normal, 280 to 295, it's probably not a true hyponatremia. There's something else that's happening here that's causing an artifact or an abnormal value. And usually we call this isotonic hyponatremia. I want you to think about two particular etiologies here. One is too many proteins or too many triglycerides. So if there's too many triglycerides, they could have hypertriglyceridemia. Maybe check your triglycerides and see if they're high. Or too many proteins. Do they have multiple myeloma? Or have they gotten some type of like IVIG or protein kind of drug? If that is the case, this can throw off the way that the sodium is calculated into the actual system. So if it's normal, 280 to 295, that's a normal osmolality. It's not real. It's either high proteins, high triglycerides. On the other hand, if it's way too high, it's not possible to have hyponatremia with a hyperosmolar bloodstream. Okay, that means you have something else in the bloodstream that's increasing the tonicity and masking and hiding that sodium. Usually, this is hypertonic hyponatremia, and it's due to high glucose or high mannitol. Okay, so either they have very, very high glucose, check the glucose, and you can actually calculate the glucose and look at that in comparison to the sodium and get a new corrected sodium level. So again, if you ever see that a patient has a super high glucose and a low sodium, plug it into a calculator and actually make that modification. It's not real. All right. If they've had a recent ICP issue and they've received mannitol, that can also skew their sodium. These are really, really important things that they can get you on the exam. What you want to see is hypotonic, less than 280. And that's a true hyponatremia. That means that the sodium is really low in the bloodstream and you need to figure out why. I then need to diverge. Is it ADH dependent or ADH independent? How do I determine that? I check the urine osmolality. I know if it's high, greater than 300, it's ADH dependent. If it's less than 300, sometimes we even say less than 100, it has nothing to do with ADH. It's ADH independent, which means that ADH is appropriately suppressed. Okay, I'm going to go the ADH dependent route now. When I look at this, again, I want you to think backwards here for a second. In a patient who has a decreased effective arterial blood volume, that's going to activate the RAS system, right? And patients who have SIADH, that's going to increase ADH, right? So in patients who have hypovolemia or hypervolemia, they're going to increase their RAS system and increase ADH production. In euvolemic hyponatremia like SIADH, that's going to increase the ADH production by the pituitary or by an ectopic site. What's the ADH going to do? Go to the actual V2 receptor in the collecting duct, reabsorb water. There's going to be less water in the urine. The urine osmolality is going to be high. In a patient like this is super common for ADH-dependent hyponatremia. For the ADH suppressed, it was low solute intake, high water intake. In these patients, their plasma osmolality was low. They suppressed ADH. If ADH wasn't present, what did it not do? It did not reabsorb water. What happened to the water in their urine? It was high, and therefore it was dilute, and that's going to be a low urine osmolality. So this is where you have tea and toast, beerpotomania, primary polydipsia, end-stage renal disease. This is where you're going to have all the hypervolemic and hypovolemic causes and euvolemic hyponatremia that we have to sift through. So now that you've done that, let's kind of move down this arm. Let's say that you obtain the volume status. If I do that and I notice that the patient has decreased skin turgor, so I stretch their skin and it kind of doesn't return, that tells me hypovolemia. If I notice a fissured tongue signifying some dry mucous membranes, that's indicative of hypovolemia. If I see lower extremity edema, that could be indicative of having a lot of pitting edema. This is concerning and indicative of hypervolemic state. And if I see jugular venous distension, this is more indicative, again, of a hypervolemic state. So with that being said, I can usually have a pretty good idea of how to determine if a patient has hypo or hypervolemia based upon that exam. If they have dry mucous membranes, if they have decreased skin turgor, low blood pressure, high heart rate, they're probably hypovolemic. If they have moist mucous membranes, JVD, they have pulmonary edema, pitting edema, ascites, that would suggest hypervolemia. Now let's say that a patient, you look at their volume status and they don't have any features of hypo or hypervolemia. That's a euvolemic hyponatremia. What was the most common one here for this one? SIADH. For here, what I want to do is, before I actually make the diagnosis of SIADH, I have to rule out endocrinopathies. Remember I told you that? So you want to check TFTs to rule out hypothyroidism and cortisol to rule out adrenal insufficiency. If you have done that, then it's probably SIADH. Then you got to go looking for brain injury, pulmonary disease, and drugs. All right. What else was another important point here for SIADH? It also had a very high urine sodium. All right, that was an important point to remember as well. Now, if I look at the volume status and they have dry mucous membranes, they have a decreased skin turgor, hypotension, they have flat jugular veins, they have features of tachycardia, and they definitely look hypovolemic. What did I tell you to do? It's either renal or extrarenal. How do I determine that? Urine sodium. The reason why is if the urine sodium comes back and I say, oh, okay, it's high, that tells me that it's coming from the kidneys. That's all renal. And that's really easy to think about, right? Because that was adrenal insufficiency, which was one big one. That's going to drop your aldosterone. SIADH is another one that can also do this. And either way, all of these things are suppressing aldosterone, and that's going to lead to what? Less sodium reabsorption here. And you're going to lose that sodium in the urine. and that's going to lead to high sodium losses. And so any kind of low aldosterone state, SIADH can cause this, but what is the big one? Diuretics. Any kind of diuretic can also do this as well. So adrenal insufficiency, cerebral salt wasting, loop diuretics, thiazide diuretics, and SIADH all can cause high urine sodium. All right, that's pretty interesting. Now, again, you're only going to see this in renal losses. For low urine sodium, that tells me that the kidneys aren't the reason why they're dumping sodium, and the body's trying to conserve the sodium to improve their blood volume. That means they're losing volume from somewhere else. That's coming from the GI or the skin. That's extrarenal sodium losses. Remember, if you have all these extrarenal losses, your effective arterial blood volume is dropped, the RAS system's activated, aldosterone's activated, the kidneys are going to be reabsorbing sodium, and they're not going to have a lot of sodium in their urine. That is the key difference here. Extrarenal, low urine sodium; renal, high urine sodium. Now, from here, if I think hypervolemic, they have JVD, they have pulmonary edema, so they have crackles, rails on auscultation, they have maybe even some weight gain, they have some pitting edema. If those things are present, it suggests hypervolemic hyponatremia. For then, I then need to kind of say, is it CHF, is it cirrhosis? Oh, do I have to really do any of that? Not really. I can just check their urine sodium. It will be low if it's extrarenal. That's your CHF or cirrhosis. All right, I'm done with that. This is pretty straightforward, right? That's not too bad. If it's low, less than 300, that's ADH suppressed. If I look at the volume status, there's only two, euvolemic and hypervolemic. So it's a hypervolemic. Oh, that one was easy. That was end-stage renal disease. If I really wanted to, I could check the urine sodium. If the urine sodium is going to be high, it's end-stage renal. But if the patient appears to have euvolemic kind of volume status, there's really only a couple things: tiantos, primary polydipsia, and beer potomania. And that's really it. Increased water intake, primary polydipsia, decreased solute, beer potomania, tiantos diet. This is the way that you can take everything that we looked at and put it together. What about hypernatremia? For hypernatremia, when that sodium is greater than 145, you don't even need to check the serum osmolality. It should always be high, okay? Because sodium is controlling their osmolality. It's contributing to it. Urine osmolality is the big answer. You want to know if the water is high in the urine or not. So if it's low, less than 600, that means that you have a low urine osmolality. That means that there's a lot of water that's being lost into the urine. That's a renal problem. That's a renal water loss. That was osmotic diuretics, and that was ADH, poor ADH release or poor ADH response. And that's it. Because again, osmotic diuresis, you're causing lots of water to be lost. And on top of that, DI, so either less ADH or no ADH effect, you're not reabsorbing the water. In both of these scenarios, you're losing tons of water into the urine, you're diluting down your urine and making it have a low urine osmolality. If it's high, that tells me that the kidneys are having ADH present and it's reabsorbing it, right? The other thing I would be thinking about is aldosterone's kind of maybe on a higher side too. So in these patients, I'm thinking that they have a low effective arterial blood volume. In this particular situation, this could be because of an extrarenal loss, skin, GI. They're depleting their water. The RAS system gets activated. ADH gets activated, goes to the kidneys, reabsorbs water to replete their water loss. And then what happens to the water in their urine? It's low. So what happens to the urine osmolality? Goes up. This is going to be your GI losses. And so that's really pretty straightforward, right? So here, let's now say that I look at the volume status here, because I can take diuretics and I can take ADH or DI and separate them based upon their volume status. If I look and I say it's euvolemic, that's DI all day. So then I have to say, okay, if it's DI, I need to determine if it's central or nephrogenic. How the heck do I do that? I give them ADH, also known as DDAVP, which is desmopressin. Now here, let me explain. I give a patient desmopressin. When I give them the desmopressin, their urine osmolality goes up. That's central DI. Now here's why. And these patients are not making ADH, all right, from their posterior pituitary. You're going to give them DDAVP to replace that. It's going to stimulate the receptors, reabsorb water. Are you going to get water in their urine? No, not as much. There's going to be less water. What happens to the urine osmolality? It goes up. That tells me that the problem is an ADH production problem. If I give them DDAVP and there's no change, it means that they're making ADH appropriately. It's just the receptor's not responding. So they have ADH present. I give them DDAVP, they both bind to the same receptor. It's not going to matter. Are they going to reabsorb water? No. So what's going to happen to the water? It's going to be dumping into the urine, and they're going to have no change in their urine osmolality. It's going to remain diluted. That's the concept and how you differentiate these two. All right. Now, for hypovolemic, it's just diuretics, right? That's pretty straightforward. If you really wanted to, you can say diuretics for the renal water losses, and that's done. So if the urine sodium is high, what do I got to do? Oh, that's osmotic diuresis. That's it. That's probably going to be those patients who are having lots and lots of water loss. So osmotic diuretics are going to be the big one. All right. Hypervolemic hypernatremia. This one's actually all primarily hyperaldosteronism. So I can just check a renin and aldosterone level if the patient has hypertension, hypernatremia, and hypokalemia. If I do that and it comes back high aldosterone, low renin, which one's that? That's primary because that's the adrenal cortex problem. If it comes back high and high, that's a secondary problem, secondary hyperaldosteronism. For extrarenal, all I want to do is check the urine sodium, and if that's low, again, what it's telling me is that aldosterone is cooking, baby. Aldosterone's going over to the kidneys and it's trying to get lots of sodium and water into the bloodstream. That means the kidneys are working, you're losing volume from somewhere else. Where are you losing it from? Probably from the GIT or from the skin. And that's how we evaluate hypernatremia, baby. Now, we've thoroughly evaluated hypo and hypernatremia. How do we treat these patients? Patient comes in, they're saying, okay, less than 48 hours, I've had hyponatremia, symptomatic, meaning they're having high ICP or seizures. So what's the high ICP look like? Headaches, nausea, vomiting, reduced level of consciousness, maybe even worst case scenario, they're developing herniation signs. If that happens, you need to treat the edema or treat the seizures and get the sodium up until they stop having those issues. So concept here is if they have cerebral edema, you got to get the sodium up, and you're going to do that oftentimes by giving them a very concentrated sodium solution. It's called 3% hypertonic saline. All you're going to do is give them lots of sodium to pull water out of the brain tissue and reduce the ICP or stop them from having seizures. Oftentimes what we'll do is we'll give them a couple boluses. We'll give them like 100 milliliters. We'll recheck the sodium in a couple hours, and if we haven't gotten at least 4 to 6 increase, then we can keep going a little bit more. Once we get to about this, you're not going to get any more benefit in reducing ICP or stopping seizures. So you don't need to go any more. You're just going to cause harm if you go too high. So initially, we'll give them 100 milliliters of 3% hypertonic saline, bump it up, stop the seizures, reduce the ICP, check the sodium, see what happens. Have I got up to 4 to 6? Okay, stop. If I haven't, I can give them another bolus and reevaluate. It's important, though, and after you recheck that sodium and you've given them like 2 boluses, that they're above 6 to 8 in a 24-hour period, you can't give them any more, and you might have to give them a little bit of water to bring that sodium down so that after the 24-hour period, it's not above 6 to 8 of a bump from their initial sodium, okay? You don't want to cause osmotic demyelination syndrome. So that's how we'll treat cerebral edema or seizures. If the patient has hypovolemic hyponatremia, though, and you've actually, let's say that this patient comes in with this feature, you treat them. Afterwards, you then kind of treat their underlying cause. What's the problem with hypovolemic? They lost sodium-rich fluid. Give them back the sodium-rich fluid? Yeah, that's it. Normal saline would be good enough. And you're basically going to do 2 things. You're going to give them water, which is going to improve their water. And then if you give them normal saline, it's high in sodium chloride. You're going to improve their sodium. And then on top of that, you're going to improve their blood volume. All of these things are the perfect scenario. For euvolemic hyponatremia, this is all to do with SIADH. Okay, so they're making too much ADH. How can I stop them from reabsorbing a lot of that water? Restrict the water intake. All right, decrease it to like less than a liter a day or a liter a day. Avoid any sodium chloride solutions. This is super high yield. A lot of the times there used to be back in the day, they would have a patient who comes in hyponatremia, give them a sodium chloride fluid bolus and see what happens when you recheck their sodium. And if it's SIADH, the sodium will drop. Here's the reason why. And a patient who has SIADH, they're pumping out ADH. You give them any bit of water, guess what they're going to do? Every bit of water, they're going to bank that and reabsorb it, and you're going to drop their sodium. So it's important to avoid water in any way, shape, or form if possible, and minimize it as much as you possibly can in these patients. If that doesn't work, oftentimes what we can do is we can give them loop diuretics. The reason why loop diuretics are helpful is because it blocks sodium, potassium, and chloride reabsorption and pulls water through the tubules and yanks all the water into the urine. All right, lots of water can be lost. If you lose a lot of water, you then theoretically can do what? In euvolemic, they just have a little bit more water than they do sodium, so I can just decrease their water down a little bit. You just have to be very careful with giving too much loop diuretics because you can make them hypovolemic if you go too aggressively. All right. Lastly is if I tried water restriction, I've tried loop diuretics and they're still having hyponatremia, that's when I can go to the next thing, which is an ADH antagonist. I can block ADH. If I block ADH, I will not reabsorb any of the water that they're taking in, and I will dump that water into the urine. They'll lose a lot of water from the body. So it's either you limit water, you pee out water, or you pee out water. That's the ways that we approach euvolemic hyponatremia. The next thing is hypervolemic hyponatremia. In these patients, it's usually the CHFers, the end-stage renal diseasers, and then on top of that, cirrhotic patients. Oftentimes, we try to do the same thing. Limit as much water and sodium intake as you can, because again, they're going to pump out ADH and they're going to reabsorb all that water, right? The other thing is that I like to give loop diuretics because why? Loop diuretics are going to work by doing what? They are going to, again, inhibit the sodium chloride reabsorption. They're going to cause lots of water loss into the urine, and that's going to help to get rid of the water from the body. That's a beautiful thing because these patients tend to be hypervolemic. They have too much more total body water than they do sodium. So giving them a loop diuretic would be the first good drug to give to these patients to really pull off water and bring the water down, and the sodium will start to rise a little bit. So oftentimes, I remember hypovolemic, give them normal saline. Euvolemic, restrict water first. Loop diuretics next, ADH antagonists last. Hypervolemic, restrict fluids, and loop diuretics. Oftentimes, that'll get you what you need to do. Let's say here, they have symptoms, it's been acute onset of hyponatremia, it's severe hyponatremia. In that scenario, if they do have that, you give them hypertonic saline. If they don't, then you kind of treat the underlying cause. But here's the thing. If you initiate hypertonic saline on a patient, you just want to, again, be very careful to avoid osmotic demyelination syndrome. What can you not go over? You can't go greater than 6 to 8. You can't go greater than 6 to 8. That's important within a 24-hour period. If you do, give them water or desmopressin to bring that sodium back down so that you don't overcorrect. If a patient has particularly an underlying cause that you have to address, you have to figure is it hypo, you, or hyper. If it's hypo, what's their problem? They're probably volume down. Give them normal saline. If it's euvolemic, what do? Restrict water. If that's not working, then what do? Okay, I'm going to give them loop diuretics. If that's not working, ADH antagonists. And that's usually going to be like tolvaptan. If I have a hypervolemic patient, I'm going to restrict water. And I'm going to try to restrict their sodium a little bit too. And then if I do that, what's going to happen? All right, hopefully that'll avoid a lot of the ADH that's getting reabsorbed. But oftentimes, what's a really good drug to get rid of the excess volume? Loop diuretics. And that should be it. All right, now let's talk about the treatment approach to hypernatremia. So in this particular patient, you have, let's say, a hypovolemic hypernatremic patient, right? In this patient, when you look at their vascular system, what do they have a lot of that they've lost? They lost a lot of water, way more water than they've lost of sodium, but they've lost both of them. Your job is to give them back sodium and to give them back water, but more particularly give them a lot of water. So in this particular patient, oftentimes, if they're hypotensive or they're a little bit unstable, best thing to do is fluid resuscitate them. Give them normal saline or lactated ringers, improve their sodium, improve their water, induce some hemodynamic stability. Once you've stabilized them, then you can start saying, okay, my sodium maybe is a little bit normal, but my water's still on the lower side. What can I do? Give them water. That's where you want to replace what's called the free water deficit. So again, hypovolemic hypernatremia, oftentimes right off the get-go, you need to give these patients normal saline or lactated ringers to improve their volume and improve their blood pressure. Then once you've improved their hemodynamic stability, then you correct their free water deficit. And that's very simple. You give them free water by having them drink it or through an NG tube, or you give them IV D5W. All that's going to do is improve their water because you gave them sodium, you gave them water, you improve their sodium, you improve their water, but you got to give them more water. If you give them more water, what's going to happen? Their sodium will be normal and their water volume will be normal. That's the goal, all right? A lot of the times the textbooks will say, try to avoid half normal saline. The reason why is you have sodium chloride. And also this can increase the risk of cerebral edema if you drop them down too quickly. But it's not as an efficient drug. If you have a patient with hypernatremia, the best thing to do is to correct their free water deficit by giving them free water and avoiding the water in like half normal saline solutions. The other big thing to remember is in patients who have hypernatremia and you're giving them water, you have to be careful because you're giving them a hypotonic solution. So if you give them a hypotonic solution, you're dropping the sodium in the bloodstream. If there's less sodium in the bloodstream, what's going to happen? The water will start moving into the brain and induce cerebral edema. This really only happens whenever you've dropped the sodium more than 12 milliequivalents in a 24-hour period. Don't go more than this because you can cause risk of cerebral edema to occur. All right, so now let's move on to the next component here, which is euvolemic hyponatremia. And euvolemic hyponatremia, the problem here is that the patient doesn't have ADH release or a good ADH response. The problem here is that they were just losing lots of water from their body. You're going to give them back fluid in the form of isotonic solutions and then replace their free water deficit. All hypernatremias, to some degree, they have a free water deficit that you have to replace. And we'll talk about how to calculate that in a second. For euvolemic hyponatremia, you have to fix their problem. It has nothing to do with the volume. You got to either improve their ADH or give them something to help with the ADH response. So here's what we do. For patients who have central diabetes insipidus, what we like to do is say, okay, what's their problem? Well, the sodium's normal. They've lost a little bit more water from their vascular system. Okay, what if I gave them desmopressin for central DI? Because that improved it on the diagnostic test. If I give them daily AVP, it should hit the receptors, they should reabsorb water, and there should be less water loss from the body, and that should improve their amount of water and actual sodium in the actual bloodstream, right? That's pretty straightforward. Simple one. Here's where it's complicated. For nephrogenic DI, it has nothing to do with ADH, it's the ADH receptor. Here's what we found that actually works, and it's kind of a weird mechanism. In a patient who's peeing a lot, you're going to give them a diuretic. That sounds absolutely insane. That's what we prefer. So thiazides, what they do is they block the sodium chloride symporter here, and if they reduce sodium reabsorption, what happens here is that you're going to lose sodium and water in the urine. When you lose that sodium and water in the urine, what happens is your blood volume gets a little bit reduced. So it reduces like a mild hypovolemia. When you have mild hypovolemia, what does that do to renin? Pumps up the renin production. When you have lots of renin, what does that lead to? Angiotensin 2, aldosterone, but guess what? Guess what angiotensin 2 loves to do? It loves to act here in the proximal convoluted tubule and reabsorb sodium and even a little bit of water. If you do this in the proximal tubule, you have less water and sodium that's going to be lost into the urine. You're reducing the actual polyuria. That's the concept here behind thiazides. It's inducing mild hypovolemia and causing the kidneys to say, hey, I need to retain some of that sodium and water and stop dumping it. That's the mechanism. And so it's kind of cool. Now, that's covering euvolemic. That's pretty straightforward. For the last scenario here is hypervolemic. So in hypervolemic hypernatremia, the problem here is that the patient has a lot of sodium and they have just a little bit more water than they should. All right, so this is your hyperaldo states usually, or a lot of sodium chloride rich solutions. So what I would say is give the patient a loop diuretic. The reason why is if you give them a loop diuretic, it'll block sodium chloride reabsorption. It'll reduce water loss here in the descending limb. Water will be retained in the tubules and you'll lose it out in the urine. If I get rid of water, what's going to happen? That's going to help to get rid of sodium and water. So I'll reduce my sodium and my water a little bit, right? Here's what I'd like to do next. Add on a thiazide diuretic, because these patients, one of the benefits of giving them a loop is you're getting rid of volume because these patients are hypervolemic, and you're also getting rid of sodium. But if you add on a thiazide diuretic, that blocks sodium reabsorption here. And if you block sodium reabsorption, you lead to a little bit of sodium loss and water loss. The benefit here is that you get a little bit more sodium loss with thiazides than you do with the loops. So if I give them a loop diuretic, that'll cause sodium and water loss more so. A thiazide diuretic will cause more sodium loss than water loss. Either way, in both of these scenarios, what am I doing? I'm going to then kind of help to normalize my sodium and then normalize my water. That's the beauty behind this. Then after I've normalized their hypervolemia and got them to euvolemia, I replace their water losses with just pure water. I know this sounds like a lot. Let's make sense of it in a step-by-step process. Patient has hypernatremia, sodium greater than 145. First thing that you have to do is determine what their free water deficit is. So if I determine that, I do that by taking their total body weight. So you take 70 kilograms, for example, multiply it by 0.5 if they're a female and 0.6 if they're a male. Once you do that, you're going to get their total body weight. Then you're going to multiply it here in parentheses what their serum sodium is, divided by 140 minus 1. Once you get this, this is the amount of water that you have to give to them over the next 24 hours to replace their water losses. Once you do that, you're going to give them free water, usually via the oral, kind of drinking it, or via an NG-OG tube. We do this in kind of patients who have mild to moderate hypernatremia. If they have severe hypernatremia or they can't tolerate oral water, that's when we would go to D5W infusions. All right, so every single patient who has hypernatremia, regardless if it's hypo, hyper, or euvolemic, they get their free water deficit replaced. You then need to figure out, okay, if I give them water, I got to monitor their sodium to make sure that I don't drop their sodium too quickly. Greater than what? I don't want to drop it more than 10 to 12 in a 24-hour period. Why? Because it can cause cerebral edema. All right, that's got to be careful of it. Hypernatremia, give them free water. Every type of hypernatremia gets this. Then think about what's actually the cause. If it's hypovolemic, what do you do for these patients? If it's hypovolemic hypernatremia, you have to ask yourself the question, are they hemodynamically unstable? If they are, then you give them normal saline or lactated ringers. If they are not, you can give them a hypotonic solution like half normal or quarter normal saline. If it's euvolemic hypernatremia, this has nothing to do with volume or any kind of IV fluid. You give them desmopressin if it's central DI. All right. And if it's nephrogenic DI, then you give them thiazides. If it's hypervolemic hypernatremia, loop diuretics. And if you need to get more sodium off of them, add on the thiazides. This is the way that you'll treat the cause, which again, if you have a hypovolemic patient, you'll give them fluid and give them water. If it's euvolemic, you're giving them desmopressin or thiazides plus some water. If it's hypervolemic, you're giving them water and a loop diuretic plus or minus a thiazide. That's the way that we treat hypernatremia. My friends, this was a monster of a lecture. I really hope it made sense. I hope that you guys enjoyed it and learned a lot. Love you, thank you, and as always, until next time.